Welcome to the Roundtable Perspective. I'm your host, Tom Roach, and I'm joined today by my guest, Dr. Darnell Motley. Dr. Motley is a research assistant professor in the Department of Medicine at the University of Chicago and director of structural interventions for the Chicago Center for HIV Elimination. Thank you for joining me.
Thank you for having me.
I suppose a good place to start would be to talk about the state of HIV in 2024 here. Who's mostly affected by this?
So in 2024, we've made a lot of important strides forward. However, unfortunately, still the folks who in our society are at the margins are still being impacted most. So people with lower income, folks of color, queer folks, transgender individuals as well, still being impacted most by HIV.
So when we talk about this now, we've got a pretty good focus on who we're dealing with then, right?
Oh, surely.
And so a lot of these strategies then are earmarked for specific groups.
If at all possible. So
Yeah.
I'll say that sometimes there's a bit of pushback to being too specific, but if we're looking at who's being impacted most, who's still having growing rates of HIV, is definitely folks at the margins.
Yeah. And what are the treatments today? How's that changed?
Okay, so if we're thinking about treatment now, there's a lot of improvements that actually have gone under-discussed. So at this point, most folks who are living with HIV can take a one-a-day medication and be able to reduce their viral load to undetectable, meaning that it can't actually be detected by our usual tests. And those folks actually are not going to transmit if they are engaged with someone sexually. So that's a great step forward. Also, more recently, within the last year or so, we now have long-acting injectables. So someone can go in, have an injection, and then come back in 2 months for their next treatment shot, which is definitely a step forward.
And how effective are they?
These are quite effective. These are sort of deeply researched interventions that we are seeing great outcomes for.
Yeah. And how is public perception on this? I assume you're monitoring that as well.
Yeah, people don't know enough, which is unfortunate. So I'll say, folks in public health, we communicate to each other a lot. We write articles, we do talks, and so we're learning from each other quite often. But in my experience, people in my outside world are asking, how are things going? Do we even have good treatments? And we've had good treatments for quite a while now. So I think we haven't done a great job at letting people know about some of these advances, in particular, the advance that now when folks are able to control their viral load, they don't transmit. The language we're using is U equals U, so undetectable equals untransmittable, and unfortunately that hasn't been well communicated out to the broader public.
So when were we first able to try to slow down the transmission here?
Yeah, so if we're thinking about sort of over time, in the early 90s, we had some level of treatment. Yeah. Those were often not well tolerated by people, so that was a bit challenging. Come late 90s, we had what we're calling so highly active antiretroviral treatment. And those medications were moving us toward much better management of the disease. Come early 2000s, we get to those one-a-day medications, which really changed the experience of living with HIV, and ideally should have moved us forward in our perception. Only more recently do we have these sort of a range of medications. So now it's not just one a day. There's a wide range of options for one-a-day medications that can help someone get their viral load under control.
That's good. And so it's becoming like many things that we treat now. We have a lot of options on ways in which we deal with it, and we can adjust for certain needs.
Certainly.
Yeah. Maybe just for the sake of the audience there, could we do a quick history of this? It first emerged in we think the late 70s, early 80s, and what were we aware of initially, and how did that evolve?
Yeah, so if we're thinking about the early 80s, we were unsure what was going on. There was a notion of a gay cancer that was spreading. With a bit more work to understand what was going on, we began to understand this was a virus, HIV. We were looking to find treatments, but unfortunately, folks were dying really rapidly back then. I wonder if folks were living for a while with it being undiagnosed, and then we were losing them. But again, as I mentioned, as we're moving into the 90s, there were some options for medication.
Yeah.
If you could get into a trial, you could access those medications.
Right.
If you could afford those medications, you could get them. But unfortunately, many folks we still lost during that time.
What was the prognosis for somebody early on there if they realized they had HIV?
I'll say from what I've heard from folks I've worked with, sometimes a few months, maybe a year. So many folks weren't able to be around very long after diagnosis.
Yeah, I remember it was like a death sentence. I think we all probably knew, a few people that were affected.
I'll say, so I used to work as a therapist for folks living with HIV, and some of the older men who were long-term survivors would talk about when they would go to the club on the weekend, they would stop at a certain point and read the names of everyone who had passed that week.
Yeah.
And it might be a very long time to hear all of those names.
Yeah, it's almost comparable to being at war because of the numbers. And so if we move this along here, what was the next big change that happened?
Yeah, getting those highly active medications in the late 90s was really such a change because the pill burden, so having to take 5, 6 or more pills is challenging for anybody. And so being able to have some a bit more effective, needing fewer medications, even if it was still maybe 3 or so, better than having 5 or 6.
Yeah.
Then again, moving into the 2000s, getting down to those one-a-day medications like a Tripla, it was such a change for folks to be able to not have to navigate that additional difficulty of so many medications and being able to take one. And when I look at now that we've got this range of medications and now these injectables, which really changes, if you can't even take if you can't take pills, you can go and get a shot and then be able to have 2 months of coverage.
Yeah. What about some of those famous cases during the 90s? I think Magic Johnson was one, and there was a high school kid in Indiana that was being discriminated against at high school because he was diagnosed. What was the outcome for some of that?
If we're thinking about someone like Magic,
Yeah.
it is my guess that Magic, because of his money, was able to access good medication.
Right.
There are folks who have the assumption that he did not have it or sort of other conspiracy notions, but I imagine that he was able to engage good treatment.
Yeah.
And when folks are able to adhere to their treatment, they do have really good outcomes. So taking, at that point, daily medication to be able to manage your viral load really allows one to be able to not just survive, but to thrive. And so I think we don't know all the details of what was going on, but I imagine he was able to access some good medication and then be able to commit to care.
Yeah. So it points out the disparity in treatments, doesn't it? Mm-hmm. So you're looking at this from a socioeconomic standpoint. What are the breakdowns that you see?
Yeah, so I'm a clinical psychologist by training with a lot of emphasis on community context. And so when I think about problems, I think about what's going on around that person that's facilitating or sort of a barrier around that problem. And unfortunately, we've known since the beginning of the epidemic that people who don't have stable employment are at higher risk for transmission, higher risk for not engaging in treatment. But we weren't really engaging or sort of we weren't intervening on that issue. So my work is focused on how do we help folks who are most at risk, usually folks who are queer, of color, and lower income. How do we get them stable employment so they can have access to money? Because if I don't have money to get to my appointment, how do I get there? If I don't have money to cover any co-pays I might have, how do I do that? If I don't have money for my rent, do I even care about other things? Can I care about other things? And so we're hoping that by engaging this economic barrier, we allow people to have much more agency in engaging in care.
So minimally, what kind of care does someone get right now if let's say they're indigent, but they're diagnosed with HIV?
So we hope folks are able to see their doctor on a regular basis, to get tests on their levels of their T cells, but also on their viral load. And then folks they're prescribed care immediately. So hopefully they're able to engage in regular care. But part of those check-in sessions is to see, are you adhering to your medication? Is it working? Do we need to make a switch to a different option so that we can get someone to be undetectable?
So the difference in care between someone who is working and subsidizing the cost themselves and someone who isn't able to do that, what is that? Is it medications? Is it guidance from the doctor? What are the big differences there?
So the care provided will be the same. The challenge is, am I able to follow up on that care? So if I don't have the stability afforded by money, can I do the things the doctor's asking me to do? And sometimes the answer is no because of those barriers.
Mm-hmm. On another topic here, what insights did we gain from HIV that helped us manage COVID?
I think I'm I'm glad we learned as much as we did so that when COVID did come, we had some perspective. I'm thinking about stigma first and foremost, right? We know that when we stigmatize a disease and the people who have that disease, there's reasons folks not to even mention they have it. And so we learned a lot around how do we talk about the impacts without making the people who are impacted feel bad about themselves or assume that they are something bad because they have this disease. Also, contact tracing. We were able to figure out how do we look at a network of people to see who transmitted to whom, which really allowed us to get a better understanding on where are the hotspots for COVID so that we can intervene and find ways to reduce that kind of risk.
Was there a big difference between the amount of resources devoted to one versus the other? And I think I know the answer to this, but I just I want to bring that up. Yeah.
It's a good question. I think the immediacy and the mortality with COVID definitely called for a lot of resources.
Yeah.
I don't think it stopped the work we were doing in HIV. We were still getting funds to do work. It was more challenging to do work because folks weren't as comfortable leaving their homes.
Yeah.
So folks' engagement and care definitely was impacted by COVID, but I think the necessity of putting money into that then so that we could try to get a hold on it was quite necessary.
So then COVID happens, right? And we're still dealing with HIV. What did you learn from COVID that helped us maybe understand HIV better? Did anything come out of that?
I think recognizing that, so there's a study I've been working on with a colleague trying to understand HIV care during COVID. And we were focused on Black queer men in particular living with HIV. And a number of them named not really feeling impacted by COVID in terms of their care. But these were folks who primarily named having a lot of difficulty accessing care all the time. So before COVID hit, they were already experiencing barriers. So when suddenly they couldn't leave the house in the same way, it didn't feel that different, which to me says that we have not done well enough yet with engaging folks who have less income, who are minoritized, to ensure they have access to good care, because one would assume a pandemic would sort of have an impact, but they were naming that it wasn't.
What kind of obstacles are we running into now? I mean, I assume that's changed a little bit. I think the stigmatism has gone a little bit, right?
The stigma has shifted. I don't think it's as much as I would have liked it to. Unfortunately, there's still a notion that people who are living with HIV did something wrong. There's a notion that there may be sort of a high number of sex partners or a lack of consideration for their health, but there are folks who are living with HIV who are born with HIV. There are folks who had one encounter and got HIV. And also there are folks who are engaging in lots of sex, as they should be able to, because we are grown people. And so there's something to, again, removing that stigma and trying to understand these are folks living with a condition. And I think moving away from a very punitive idea of HIV is to our benefit, but unfortunately we're still climbing that direction, but having difficulty. I'm hopeful that with time, perhaps through media representations of folks living with HIV, through sort of more education about HIV and how it is in the modern world, there may be some shifting in that stigma.
Is that one of the focal points of the effort for dealing with HIV right now, still to deal with the perceptions of it a little bit?
Oh, certainly. I think with the slogan, you equals you, it's been really, one of the points is to understand that you can have a partner who's HIV positive. They're not a threat to you. And unfortunately, so much of the language of the 90s was, kind of saying you can't trust your partners. And so pushing you to test anyway. You're not sure what they're doing. And that created a notion that people living with HIV were somehow folks to be avoided. And I think now we know much better than that. So I'm hoping that more information around what is real transmission risk, how are folks mitigating that risk, can allow us to engage differently.
So it's talked about less now.
Certainly.
Does that make it harder to address some of these issues?
It does. Someone once asked me, aren't we done? Because we have good medications. And my mind went to, we have good medication for diabetes, good medication for heart health, and nonetheless,
we're not done with
we're
those,
not done. And so I think there's so much more to do. But what I want to name, though, is on the prevention arm, we've definitely made progress as well. So there's a medication, well, a set of medications that we refer to as PrEP, so pre-exposure prophylaxis. These are meds you can take daily to prevent, if you are exposed to HIV, prevent becoming HIV positive. That also gives people so much more power over their status.
Maybe we should talk about that for a second here. So there's a difference
Sure.
between being exposed and becoming positive.
Yes. So, HIV is a virus, and so if you engage with someone who has HIV sexually, you may be exposed to the virus. Your body doesn't always take it up, and so having PrEP as an option is an additional barrier to, even if you are engaged in condomless sex and you are exposed to the virus, you will not develop the virus in your system because of that medication.
I see. So what kind of obstacles do we run into today then?
A lot of it's knowledge.
Yeah.
And so when I think about PrEP, for example, it is a daily medication, which not everyone wants to do.
Yeah.
And so
Well, I mean, why not?
I think
I mean,
there's
people
concerns
who-
about,
Yeah, I mean, people who have all kinds of other issues
you're right.
daily medicate themselves, right?
I think
Not that I would want to do that, because obviously there are usually side effects with these things, but why would that be more of a problem here?
I think the problem is there are side effects, and so folks worry about impacts on kidney or liver.
Right.
These are well researched, and we understand what the risk looks like.
Yeah.
And so I think some people just are not prepared to have that additional pill burden.
Right.
Again, others don't know about it. We focused a lot of our PrEP education on queer men, to a degree on trans women, but we have not really been addressing cisgender women who are at risk for HIV acquisition. And I think that's a failure on our part as public health researchers and folks engaged in that space. So I think getting information out is one of our big barriers.
Yeah. What other organizations are helping with this? Who do you interface with?
Yeah, so some partners in my work, particularly around moving toward folks getting employed as a route toward prevention, would be the Chicago Black Gay Men's Caucus, also Task Force Prevention and Community Services, and more recently, we're building relationship with the Lighthouse Foundation in Chicago as well. And so those are folks I've worked with for my current research, but other important partners are the AIDS Foundation of Chicago. They do phenomenal work. Even the Aliveness Project here in Northwest Indiana, I've worked with them before as well, and they do amazing work as well, trying to combat the epidemic, but also to inform people.
So other than providing funding, what kind of things do they do?
They are talking to people, on a daily basis, of engaging with folks, providing care, access to medications, wellness programs, psychotherapy, because the truth of the matter is HIV, while it is a biomedical issue, it impacts the whole self.
Sure.
And so there may be depression that follows. There may be anxiety that follows. And so having resources to support folks in navigating these things is critical.
I suppose that's pretty well coordinated at this point.
We are getting better.
Yeah.
I'll say that there's always room for improvement because the need is great, and making sure we're available to folks where they can access the care is very important.
So what's your wish list? What kinds of things do you wish would happen here?
My wish list is definitely easier access to employment.
Yeah.
Part of that is combating racism in employment, sort of also homophobia in employment, transphobia in employment. If we can get those things out of the way, then folks can enter employment and be able to stay there. I would even say supports in schools, because so many folks become at risk because they could not finish education, and so now they are underemployed and at higher risk. I would love to see differences in our rules for sex workers, because right now, there's women I've talked to who've been arrested for having condoms.
How's that?
Because the condom is now proof they're engaged in sex work. And like that kind of thing gets in the way of us approaching folks engaging in things healthily.
I wouldn't think that would be possible.
One would hope it weren't possible.
Yeah.
But because of our negative, and I'll say our societally negative perceptions of folks who are engaged in sex work, we find that folks don't mind being punitive to those folks, even if it gets in the way of good health engagement.
It's an interesting world we live in, where you can carry a gun but not a condom.
Mm-hmm. Very good point.
What else can you say about the socioeconomic factors here? I guess what would be interesting if you could give me an example, without naming anyone, of someone who you were working with, trying to get them employment, and what were the obstacles there, and how was
Certainly.
that dealt with?
So a previous research project of mine was called Work to Prevent, and we met with people to support them in getting employment skills. And we had usually up to 8 people in the room for these sessions, and we provide some training. Many of them named not getting calls back when they applied for jobs. Some named having experienced discrimination on jobs. I think one person in particular, a young trans woman who named working at a large fast food company, and she was working the drive-through, and when she handed the person their food, they called her a slur. And she went to her manager and said, can we trade out because I don't feel comfortable? The manager said, no, you can handle it. She went back, was called a slur again, and she threw the person's shake on them. While ideally you don't throw the shake, I understand being frustrated when you're trying to work and someone's disrespecting you just for being there.
Yeah.
And those kinds of barriers to staying employed get in the way of someone being able to have that income. And so those kinds of issues get in the way. But what I'll say is the folks we worked with, many of them, when we saw them again in 8 months, were working more hours per week. A number of them named having gotten new jobs and feeling a bit more agency to opt out of places where they didn't feel comfortable or didn't feel respected.
Yeah. So the training you provide, generally, what are you saying?
So part of it is sort of recognizing your skills, your aptitudes, right? We all have something to bring to the table. And so helping people to recognize what those things are, how to put that into a sort of a quick 30-second pitch. Also some interviewing skills, resume development, but also how health impacts work, how work impacts health. So folks are thinking about this more holistically.
Yeah, well, a lot of that is what we do at the university when we're preparing people to graduate. So lastly here, I know that you also recently were a co-author of an op-ed on how to fight HIV epidemic in black neighborhoods. What's your message there?
Yeah, I think unfortunately because, and this is also a COVID lesson, because of who's most impacted, there isn't always the same priority placed on engaging this health issue. Because there's a notion that we've gotten so much farther. But until we really engage the folks who are most impacted, the folks who are being underserved, we cannot end the epidemic. And so if we are going to meaningfully move toward ending the HIV epidemic, we've got to engage with folks who don't have stable income, who are impacted by racism, again, and homophobia or transphobia. And that means taking those things seriously and recognizing until we address those system level problems, we can't end this problem. And
who addresses these things? It's something that's things that are funded maybe by the state, by the city. Where does the help come from?
I think this can happen across levels. So if we're thinking about healthcare, making sure that doctors understand how to be respectful to someone who's trans when they come in. So that may be at the medical school level, that may be in the continuing education level. There could be campaigns funded by whomever's willing to fund it. I would love a federal campaign that's sort of speaking to respect for your patient as good healthcare, as sort of moving us toward being able to eliminate these disparities.
Yeah, how would you coordinate something like that? I mean, that's a pretty huge.
Someone should fund me to do that.
Project, yeah. Well, and then what about the black neighborhoods themselves? Do you need more cooperation there as well?
We just need more access, right? I mean, in general, we need men to engage in healthcare. That's a larger problem. But I think to be able to partner well, I'm not sure if that means partnering with barbershops as a space to talk about sexual health, or beauty salons. That's been tried for other
There's evidence that those are key places for.
Yeah, we've seen it with like heart health, diabetes, and I'm hoping that, given that these are spaces where folks do talk about sex sometimes, if we could have a conversation on sexual health, could that be an effective space for folks to learn more about that? Also, the church is a space that could be. They're well located. They could be a good partner if they're willing.
Interesting. So if somebody wanted to help the effort here, what might they do?
So I think there's many ways. One, getting yourself educated about HIV. The more you know, the more you can spread to people who you know.
So again, watch Roundtable Perspective.
I can definitely watch here. And I would love folks just to be very thoughtful about learning more and engaging and then sharing information with folks around them.
In terms of volunteering, are there any organizations that could use some help?
Yeah, I know in the city of Chicago, the Center on Halsted would love volunteers, Howard Brown Health, even the center where I work, the Chicago Center for HIV Elimination. I'm sure we could utilize some volunteers as well to support our programs.
Okay, that's all the time we have for our program. Thank you to Dr. Darnell Motley for joining me on the program today. I'll see you next time.